Hi, everyone. Welcome. Thank you for joining us. We know there are many intriguing and competing sessions, but we're very happy that you're here. My name is Lonnie Riley. I am the VP of Patient Access at the Digital Therapeutics Alliance. If you're not familiar with that organization, we are the nonprofit trade association for the digital therapeutics industry. Please come and ask me more if you have questions about that. I'm so excited to be with these wonderful panelists who I will have introduce themselves in a moment. We are presenting a talk on deploying with AI to break health inequities and labor shortages. So with that, I will pass it on to my panelists and have them each provide an introduction. Welcome.
Anybody hear me? Right. Hello, everybody. Welcome. This is Prashant Brahmandam. I'm the Chief Technology Officer at Backpack Healthcare. We are a pediatric and family mental health provider through therapy and psychiatry. And my role specifically as a CTO is to build our AI-led innovation platform or tech platform to support all the clinicians and patients with their entire care journey. Prior to this, I was at Meta. I was the global head of strategy for technology and analytics for all of the products that you know them for, Facebook, WhatsApp, Instagram, and the metaverse. But I think my work here is probably one of the most meaningful I've done probably in my entire career, and I finally feel like I'm doing good, using tech and AI for doing something good as opposed to what I did at Meta. Yep.
Hello, my name is Ignacio Handel, and I'm the CEO of Clinicom Healthcare, Inc. Our mission is to bring equity and access to all in mental health, no matter what country, language you speak, but that we believe that everybody deserves a complete and thorough mental health assessment and to be able to have their voices heard. We spent the last 20 years doing a litany of hundreds of FDA clinical trials. We've actually put a lot of the meds in this space to market as an individual site for pharma doing testing in phase 2 and phase 3. And we've leveraged, I guess, those funds to build our augmented intelligence we call Clinicom, which I'll tell you a little more about in a little while.
Hi, everybody. I'm Angela Skrinsky. I'm the lead physician for telehealth at Virtua Health, which is the largest health system in southern New Jersey. And in that role, I have the pleasure of not only leading our telehealth practices, but also, just as importantly, working with the Digital Transformation Office, which is sort of the innovation incubator at Virtua to bring various digital solutions to the organization to serve our community. And one of the things that I'll talk to you about today is that we've been one of the first early adopters of implementing Wobot, a mental health chatbot, in our organization and offering it to our patients. And we've had some really great success, and we'd like to continue that journey of finding innovative solutions to bring access to healthcare for our patients.
Hi, everyone. Thanks for being here. My name is Alison Darcy, and I founded a company called Wobot Health in 2017. My background is a clinical scientist, basically a psychologist by background. And I founded Wobot to try and break down some of the big burden and hurdle to access to some of the great tools that we have in the clinic. It's been an interesting journey, and I'm looking forward to sharing it with you all today.
Hi. If you look at the slide, I'm not supposed to be here. But that's because I thought I wouldn't be here, and then at the last minute I was able to join, so I'm happy to be with you. My name is Tom Insel. I'm the psychiatrist for this group. So I actually have a background as an MD and spent many, many years in research, ran the National Institute of Mental Health through the Bush and Obama years, then moved to Silicon Valley, where I've been in a range of startups in behavioral health since. The one that I'm here to talk about is called Vana Health, the company that I co-founded 2-3 years ago. We work in a different kind of space. We work on the street with people who have serious mental illness, often been incarcerated, may have been homeless, may currently be homeless. And we, oddly enough, though it's more high touch than high tech, there's a really important role for technology and AI in helping that population, which I'm excited to talk to you about.
Wonderful. Thank you, everyone. So just to set the stage a little bit, we have this big problem in this topic, which is health inequities. And we have a problem that we need to work on as well, which is clinician and labor shortages in healthcare. And so to help us understand how each of you are solving parts of that problem or those problems, can you give us a little bit of context? And you don't have to go in order down the line, but you can. And let us know, from your perspective, what problem are you trying to solve?
Sure. Thank you. When it comes to health inequity, I think that one of the biggest problems is with patients and access that the patients have. And this starts with awareness, really, because most people are not even aware of mental health as a condition, and let alone all the details of all the flavors of different mental health issues. And once they overcome that, again, there's a question of stigma, because when they understand it, they don't want to talk about it. That's the other big problem. When they overcome that, then there's affordability, because it's not cheap for most communities, especially those that are in rural communities, etc. It's not easy and not affordable. So that's the third problem. And the fourth one is of access to quality healthcare in the way they want, at the times they want, overcoming all of these conditions. I think that's one of the combination of all of these lead to more health inequities and more conditions, and it's a vicious cycle that perpetrates itself. That's one side of the story. I think the second thing is with clinicians. We all know there's a massive shortage of clinicians, maybe almost by 10x the demand. And the health, mental health tech is in the Stone Ages. That's the other problem, which leads to clinician burnout and lack of ability to kind of scale clinicians. So I think the two together is almost kind of causing this perfect storm scenario with mental health and inequity in this country.
Mental health in America is broken. 80% of our SSRIs are prescribed by primary care doctors with no mental health training. They sprinkle drugs on our families like, oh, you're depressed, take some Prozac, without checking to make sure that the symptoms are checked and that you actually have these conditions and it's not something else. And so I call it the medication merry-go-round, right? 60% of counties don't have a psychiatrist. Our core primary care groups are nurses, our nurse practitioners, our counselors. They're doing all the heavy lifting. And they don't have the tools and didn't go through psychiatric residency. So how do we empower those in the middle? How do we give the knowledge, or at least a framework of a psychiatrist's knowledge, to somebody who maybe didn't have that kind of training? So our vision at Clinicom was to take the DSM, and we started at DSM-4, and now we're 5TR, and try to create patient-facing questions to each and every one of the criteria, both in first person, third person, and pediatric versions. We copyrighted that back in 2008 and then created an augmented intelligence to ask the right questions of the patient as you go through. As an example, if you were hit in the head and you were in the military, we deploy the TBI algorithm in the military history question. But if you're not, why am I going to bore you with a bunch of questions? The other big problem in mental health that I think creates a lot of inequity is bias. We're having another human judge another human, inserting their clinical bias, their training bias, their biopsychosocial internal bias, and then plating that onto another human being as okay. So how do we remove that bias and create objectivity and let people give a voice to the voiceless and give them the air in the room to tell their complete story without being rushed out of a room, without somebody looking at a watch, and be able to tell their full journey in an encrypted, safe place that then if they're not happy with the care they're getting, they can then take that data and move it to the new clinician and not have to open up Pandora's box with their traumas all over again. So that's part of the solution we're trying to solve for.
At Virtua Health, in my role there, one of the things that we think about often is when we're bringing digital innovation, we're thinking about solutions that are going to really help three audiences. Yes, of course, the patient, but also the clinicians and the staff. Because if we're not implementing things that are helping all of those audiences, guess what? Technology can be great, but it's not going to get used. And so, that's been really important to us in evaluating any solution that we're implementing. And when it comes to healthcare and innovation, I think what we're really trying to do is the healthcare has become so much more increasingly complex over the past 5, 10, 20 years. And patients are navigating not only access issues, not only cost, but really think about the medical literacy that you need to have in order to understand and navigate co-payments, co-insurance, deductibles. And you pair that in the world of mental health with, feeling demotivated, fatigued, stigmatized. So what we're really trying to do is make solutions that are easy. We're trying to teach digital literacy. We're trying to engage patients in medical literacy. We're trying to get clinicians and staff on board to move these initiatives forward. And I think those are really the things that are top of mind for us when we're bringing digital solutions.
That's amazing. From our perspective, I think, as an intervention scientist, it's quite frustrating because I know that we have these tools that work. CBT, for example, great treatment approach, and one that I think is very empowering because it's about kind of what you're thinking now, what you're doing now, and can we reconstruct that so it supports your health better. But what we've done is made them only available in the clinic. So that's kind of like an enormous access issue. So I think a lot of treatment, by definition, it's intimidating and it's difficult. You mentioned all of the hoops that someone has to jump through. Now imagine you're 15 years old. Mm-hmm. The amount of maturity that a child has to have to try and go to their parent. They may even not know what's happening to Prashant's point. To then hopefully the parent has the resources to get in, and then to be told, well, you're going to have to wait a few months to, right? And all of these ridiculous complications are getting in the way of somebody being able to utilize something that can help them immediately. So what we were trying to do was, can we reconstruct some of those great skills from CBT and put them in the hands of people and try and shift the entire conversation earlier? Not that we're delivering treatment, but so much of CBT is based on sort of practice and the stuff that you do between sessions. So could we just bypass all of that stuff? The other issue with all of the institutions and what I kind of call the architecture of the clinic, while all of those things are important, they can have, as you said, humans have bias, and a lot of that bias then gets baked in at an institutional level. Mm-hmm. So if you're somebody of color or you are from a demographic that is not as well represented, it's a much, much, much more difficult task on top of something that was already difficult and stigmatized. And of course, what we know about the real one of the major things that prevents people from getting help is stigma, which is amplified if you are from, a demographic, if your people are not represented when you go and actually seek that help. So, Wobot was one teeny tiny, little innovation, trying to overcome all of those things in small conversations delivered, as someone lives their life.
Well, that's quite a list of problems. but Lonnie, I think this is actually the right place to start because it's we often assume we know what the problem is that we need to solve before we really put the energy in to figure out what that is. I spent a couple of years on just that question, like what's the problem we need to solve here? And I actually wrote a book called Healing based on work I did traveling mostly around California, but around most of the country and much of the world, talking to a lot of people about this and trying to figure out, to Ignacio's point, it's like, why is this so broken? I mean, I went to medical school 45 years ago, and we did better in this area in psychiatry than we do today. That is not true in cardiology, diabetes, oncology, any other part of medicine. We have just not been able to see the progress. So why? And I guess I would say that some of it has to do, I kind of came up with 5 bullets, some of which we've covered here. The first one was capacity. We just don't have the investment. We don't have the safety net. We don't have the workforce. We don't have the beds. There's just a bunch of things that we have in other parts of medicine that we don't have here. We used to have it, by the way. So the idea of incarcerating somebody with mental illness was unthinkable when I was in training. Today, it's the rule, not the exception. So I think capacity is a piece of it, but there's the bigger issue, I think, is actually, at this meeting we talk a lot about access. I don't think that's the problem. I think a bigger problem, particularly for people with serious mental illness, is engagement. So even when they have access, it's so different than when you're treating someone with cancer or heart disease. The sicker they are, the more likely they'll be in care. We're the flip side of that, right? The sicker you are with mental illness, the less likely you think you're ill, the more likely you'll avoid care, or you don't buy what we sell, is a simple way to put it. So engagement is a really hard problem to solve, particularly for people with serious mental illness. And that was kind of the idea we went after that at Vana. We also were thinking about 3 other areas that really popped up. One was that it wasn't, when people do get engaged in care, the quality isn't great. And we haven't done a very good job in this field in raising the bar on quality and requiring providers to actually do the things that work. And that's one reason why we haven't seen public health outcomes. And the fourth thing was there's no accountability. So this is largely a measurement-free discipline, so different from diabetes or hypertension or most other areas. We don't measure. And if you don't measure, you don't manage well, you don't see the success. The fifth one, which is really the problem that I got wrapped around, I called equity. And it was based on a bunch of stuff I looked at, trying to understand how do people with serious mental illness, schizophrenia, bipolar illness, severe PTSD, maybe really bad OCD, how do they do with respect to the measures of sort of social justice that we care about? So are they going to be employed? Are they going to be housed? Are they going to be incarcerated? Are they going to be involved with a violent episode with the police? Do they have early mortality? And they actually do. They die about 23 years before the rest of the population. So as I made a list of those, I thought, gosh, if this was a racial ethnic minority, where would they sit in the United States? What would they look like? And so I actually got the regular numbers, the sort of comparative numbers for all racial and ethnic minorities. There's no group in America that is more disenfranchised, more marginalized, has worse outcomes on everything from mortality to unemployment, you name it. Likelihood of being shot by police 7 times greater than any other racial ethnic minority. So, and likelihood of being incarcerated, 10 times greater. So you've got really an extraordinary set of outcomes that's a real problem that I'll call equity. And so Vana came about by saying, how do we fix that? Like, if that's the problem, if you've got Dalits, you've got untouchables in America, how do you actually begin to solve for that? And it was the weirdest thing that actually what we're going to talk about, which is like, using technology does have a role there, but it wasn't obvious at the beginning.
Wow, thank you for framing that up so nicely, Tom. And I think you not only listed the enormity of the challenge that we face, but also summarized kind of what everyone had said that came before you. Now we get to the part of technology and how do we leverage technology and AI to help with all of these problems. And one thing that you had mentioned, so I'm going right back to you, Tom, when we prepped for this call is, AI is a really hot topic. It's a big topic right now, but it's not a new topic per se. We've been talking about, the use of intelligence over time. And so I'd love your perspective on that. And then I know that some of our panelists have some supportive statistics to share around that as well.
Yeah, I don't want to drag us back into ancient history, but it's worth remembering that we've been here before in various ways, and I guess the story usually begins in about the mid-1960s at MIT when Jacob Weizenbaum was a computer scientist and said, how could we use this in a really cool way? And that was the era of Rogerian therapy, which was a very popular psychotherapy. It went something like this. You sit down with your therapist, you say, I feel bad. And the therapist says, you feel bad. It doesn't seem like a really powerful intervention, but it was a very popular approach. It's just called reflective therapy, that you keep helping someone to reflect on what they've just said by repeating it. Not too difficult to actually, develop some code that can do the same thing on a machine. And so Weizenbaum did that. and created something called ELIZA, which was the very first really use of what we would call an AI type agent as a bot therapist. 1965, amazingly. It went about as far as Rogerian therapy went, which was not very far, but still, it's pretty interesting if you think back about it now, what are we, 60 years later, that in the 1960s, a computer scientist who was thinking about all the ways in which I could try to use computer intelligence to do something in the real world, the first thing that was picked up was psychotherapy. That's really interesting to me. And it's become, of course, very much a legacy project, which people have now iterated on throughout these 6 decades, initially getting into ways of capturing with natural language processing, capturing voice and speech, and getting much deeper and objective measures of how is somebody feeling, and then more recently with generative AI, and now the most recent stuff is actually going beyond generative AI as text, but adding voice and adding avatars and all that. And all of a sudden, it's like in the last 2 years, it's become a very different enterprise, really interesting. But the point is that we've been at this for a while, and a lot of the diagnostic stuff, the natural language processing stuff, actually tracks back to University of Texas work, 20 years ago, where a lot of great stuff was done to understand the structure of language and to be able to capture linguistic signals that were objective measures of sentiment or of mood.
Thanks so much, Tom. I think, we wish maybe that since we've been at this for such a long time, we might be just a little farther down the road by now, because what we see is the work shortage and, the inequities that exist now that maybe could have been helped more along the way. And so to, tee up the next part of the conversation, I'd like to ask Ignacio and Prasanth to talk to us a little bit, statistically speaking, where we sit now with these shortages and inequities. So I know you had some statistics to share.
Everybody knows some of these stats. 60% of counties don't have a psychiatrist. Most of the SSRIs are prescribed with primary care. There's a huge shortage. There's like 900,000 therapists and 38,000 psychiatrists. You're more likely to run into a librarian than you are a psychiatrist in America, which is kind of shocking. It's a 16-to-1 ratio of MD psychiatrists to therapists, and how do we support our therapists better? It's an imbalanced system, right? And so part of, I think, the historical evolution of AI, and we've been working on this problem also since 2003. We did our first digital remote comprehensive mental health assessment in 2004. Is the natural evolution of how things have to progress to get to the next level, right? Now, you guys all noticed in the last 2 years with large language models, all of a sudden there was an explosion. But that core work was happening for 15 years, right? We also internally realized that AI was actually a problem for mental health and assessment. Hallucinations, we had tremendous issues, and we had to go back to the drawing board several times over the last 15 years to get our product correct. And what we realized was that it's really not just AI. It's something that we called, we called it 12, 15 years ago, augmented intelligence. How do we augment a clinician's knowledge base and support them to make their best decision, not some robot or bot making the decision for them? How do we inform them with the criteria, the DSM criteria, the things they need to know, the biopsychosocial elements, the histories, the epigenetic connections, all that package that up for clinicians so that they can make the best decisions. And so the exciting thing to me is now the natural evolution is that I think people looked at large language models as the solution to all of it. And the truth is it doesn't work without a strong neural net foundational base. In a book form, we call that the DSM, but in a digital form, I call that Clinicom. But once you have a strong foundational base, then you can layer on AI on top of that. And that's when you can do some really exciting things, like predictive analytics and prescriptive analytics, or, please tell me how Prozac working in 16-year-old girls in Wichita versus Miami, right? If your database is based on the rule set we all can virtually all agree on, and you're not creating hallucinations, then you can ask some really interesting questions. And so I think the next evolution and how that's evolving is going to be pretty exciting and also pretty jarring for people. I see a future where people will be disclosing their most sensitive stuff to a virtual agent, and their clinician will read that and understand that and summarize that. But our veterans won't have to open Pandora's box to unlock their traumas every time they go to see a psychiatrist. Or if you change your psychiatrist, you won't have to reopen your traumas. They'll just read your report, right, and track your progress. So I think this will bring privacy, deeper privacy, but also deeper connection, where clinicians are not spending their time talking about chief complaints for an hour or 20 minutes or rushing you out of a room, but where you're tackling things in a more efficient way from the start. So it's an exciting future.
It's awesome. Great numbers, great statistics. I want to kind of add on to that. So I want to talk about maybe two things: the size of the problem and the degree of the problem. I think in terms of size, and Ignacio was talking about the number of the ratio between MDs and psychiatrists. So one of the things is there's about at least 20% of the population has been diagnosed with a mental health condition. So it's about close to 60 million people in this country. There's probably a much larger number that is feared to be undiagnosed. So you're probably over 100 million people who likely have condition, diagnosed or not diagnosed. In terms of the number of therapists or clinicians, we're at maybe a few 100,000, maybe 500,000. So the ratio is close to 1 to 200 when you talk about clinicians to patients. So even if a clinician could see 20 to 30, which is kind of a reasonable upper limit, and every clinician in this country was seeing to the max, you're still at about 10 to 12 million people, which means there's still a 10x gap between patients that can be seen and patients that they are in this country. So that's the gap we're talking about. So that's the care gap between the demand and the supply. So that's the first one. The second I want to talk about from a degree of the problem. So after accidents, suicide is the primary cause of death for people under 35, which means more people die of a mental health condition than any physical health condition. Dr. Insel talked about diabetes and hypertension and cancer, et cetera. And there's so much focus about that in the country. But more people actually die because of mental health under 35. And there's just not enough awareness. Everybody has a PCP. Not everybody has a therapist or a clinician that they talk to. So that's the other problem that we're trying to solve. So both in terms of the number of people who are likely affected, as well as the gap between what we and the focus on that problem in the country. And then Dr. Insel was talking about technology is probably the only way we can handle something like this, which is true, because AI is probably the only way you can actually mitigate this gap. There is no other viable solution that is anywhere close to mitigating this gap. So I would almost say that it's negligent of companies or mental health providers to not look at AI or not explore AI. I'm not saying use AI, but if they don't explore AI, given this kind of a problem, they're sitting on resources, they're sitting with clinicians, and they're burning them out, not using this technology that is there. And this is really the only way to bridge this crisis. So that's, I think, where we are.
Agreed. I mean, coming from a clinical perspective, all of us know that if you're one single person and you have, one prime time therapy slot that's desired by a wait list that's a year long, it feels insurmountable, right? It does. And I know that, Ali and Angela can add context in terms of, what AI can do to mitigate some of that. And, given our very short amount of time here, because we have a very long outline, we talked for a long time, all of us. I'd also like to just insert, there are direct benefits, but we also know there are risks, right? And so let's talk a little bit about that, both sides of the coin, and I'll point to Ali and Angela to get us started there.
Risks. Yeah, I'm happy to talk. I think, as you'll have heard with all of our panelists today, AI is just a tool, just like any other, and you can wield any tool for good, or you can do a lot of harm. And so I think it really comes down to, I think a lot of the conversation has been, oh, these bots, do they work? Or, oh, these, they're dangerous, they're terrible. They can be very effective and they can be very risky. And I think we have to move the conversation on a bit further to what makes something helpful? What are we how are we measuring that? What's the intended use, right? With what population, when is it useful? When is it less useful? And then come back to the sort of ground truth of, is it moving outcomes or not? And so that's why we've done a lot of studies. We've done 18 now, I think, randomized clinical trials. I think looking at more than, I think it's more than 20,000 patients now, or individuals, and we're able to say a lot, which is really interesting. We can say a lot about the circumstances in which somebody can really respond and use a tool like this, and when they can't. We can look at what are the characteristics of people that do well. We've seen, interestingly, so we will look across demographic groups and look at all of our outcomes that way. To see are there a particular group that is responding differently, and so I think, look, that's the kind of one of the big risks is, like with any risk of any device or anything any tool that we use, how is it being used, and to look at it in an individual way. And I think the key to that is really good science, humility, right, guardrails, and some sensible regulation is going to be part of that equation as well. The other risk I would say is that, and I think this is a public perception risk when we look at a conversational agent that has had a really terrible outcome and we mistake that for being representative of the entirety of the category. If we start to sort of think, well, these things are just like not useful, and tar them all with the same brush, then we are potentially missing out on a very important opportunity to use some technology that can actually move the needle. So I actually think that's the bigger risk, is like we approach the field not thoughtfully and lose this opportunity in public health. And so I'm giving you the typical risks, right? Because I think there are other risks, but I can tell you one thing that we have found that actually we have not found it in our data, that people will often say that people will become dependent on something like a Wobot and then not seek care. We have actually found evidence of the opposite, that people have a really good experience with Wobot and are more likely to then seek care afterwards because they get a flavor of what therapy might look like. Obviously, Wobot doesn't do therapy; it does, elements of CBT. But nonetheless, they get a feel for, oh, this is actually, this is okay, and I can do this. And there's a sort of a practice of externalization that they that then boosts their confidence to seek more help, which I think can be only a good thing.
And I think that speaks to the engagement problem a bit, right? When we were thinking about how tough it is to engage people that are experiencing serious mental illness or are feeling stigma, it's great to give people a tool that then may propel them into further help. That's great. Thanks for that point. Yeah.
Yeah, I think you said most of all the important points, right? I think we need to think about the fact that although we really have to be very pragmatic, especially because this is all new and it's scary to many people. And so part of that is going a little bit slow, even for those of us who in innovation really want to move this forward. And then balancing that with the idea, what is the risk if we don't implement this? That's the point where we've been able to demonstrate such success in our implementation of Wobot that we're now talking to our clinicians and saying, listen, if you have a patient for whom this can be beneficial and you're not offering it, you're now doing them a disservice. This is a part of your toolkit that needs to be something that you think of hand in hand with therapy that then supports that. And when we're talking about risks, I think there's a lot of that piece that is about communication. So not only the mitigation of those risks, but also communicating to patients and to clinicians and to staff and to whomever you're trying to get on board with this solution that you've thought about those things, and here are the pieces that we've put into place. Here are the guardrails, right? Here are your safety nets. And I think that's just very, very key to ensuring that you continue to drive these things forward. Otherwise, we are going to continue to have all the problems that we see, these access gaps and everything else.
I'd like to add something about the risks, and this is very real and kind of scary. We kept Clinicom in stealth mode for over a decade. Why? Because we were making a lot of mistakes. We were self-funded. We had our pharma studies to fund our development. We didn't require them VC and PE, so we could take our time to do it right. But one of the things that I think we realize, and I want to share with you guys, are lessons learned, because if you're in a digital health company or you're also using these tools, some of the dangers that we saw in large-scale studies of 100,000 plus things. So sadly, I see a lot of digital health companies using BHT9s as a diagnostic tool. It's a very dangerous practice. We see tons of 100,000 cases where patients were presented as not depressed on a PHQ-9, but they had persistent depression disorder. Or they had a high PHQ-9 score, and in a primary care setting, they probably got sprinkled SSRIs, and the reality was they were bulimic, right? So if we don't stop and look, and stop to do things the correct way, and look at the entire person, and just stack digital assessments on top of each other, what we learned was after 4 or 5 stacked digital assessments, it becomes tone deaf. People stop filling it out. People don't want to give you information. If you're asking about my insomnia and I don't have insomnia, or if you're asking me about my psychosis and I don't have psychosis. So the secret sauce was to ask the right questions of the right people and not drop any balls. But the danger in it is some of these tools, for example, the PHQ-9, most people might not know this, CMS made a huge mistake in my mind of telling everybody, hey, use the PHQ-9 for all the HIPS, METIS, VBC measures, when the FDA studies, they will not allow us to use a PHQ-9 as a primary endpoint measure. So why the dichotomy, right? So I think people need to stop and think if what the danger is of these things that can hurt people, and not to release things in an MVP status, but really think it through ethically, morally, and from that place of do no harm.
Thank you for that.
Yep. I do want to add one more thing to what Ali was saying. And we rolled out something called a Care Companion, which is an empathetic chatbot that can talk to patients in over 200 languages, and kind of it was meant to be a support tool for both parents and patients to kind of understand the mental health condition and kind of get to that overall access and stigma problem that we were talking about. And to add to what Ali was saying, what we've seen is like parents are actually understanding the condition much better now. They're able to talk to the chatbot and understand what the kids are going through. And she's right. I think it actually helps a lot of people get into therapy that they were not going to. So I think a tool like that definitely helps. But the risk with that, obviously, is that it has to be done right. Everybody's probably heard the story about Character AI, where the kid committed suicide because it's not built on a responsible AI framework. So one of the things that we've been very careful about with excessive testing is to ensure that every output of the large language model is evaluated by a bunch of other models to check for hallucination, toxicity, harm, and any kind of violence, et cetera, and escalate to the parents, to the clinicians, to other authorities when we see that kind of language. So it takes a lot of effort and responsibility to put a responsible AI framework that is unbreakable. And it's really important to do that because you're putting these tools in the hands of children. Like the Care Companion is being used by kids that are like 9 and 10-year-old. If it's not bulletproof, it can cause more harm than good.
Absolutely. Tom, did you want to weigh in here?
Yeah, I think these are all great points. One thing we haven't talked about, I think we just, before we wind up here, I want to make sure we have a framework to talk about this topic, because usually AI conversations quickly get into the bots. But actually, most of the application today is not there. It's elsewhere. So when I'm asked to talk about this, I usually talk about the 3 Ds. So documentation is a huge opportunity yesterday with the AI tools we have already. In the world I'm in, our community health workers spend 50% of their time documenting what they do the other 50% of their time. With digital scribes, with the tools we have now for summary, for documentation, for sending in billing, all that stuff, push of a button, we can double our workforce with the tools we have right now if we start to put them into play. So AI has a massive impact on providing summaries, providing translations, providing the kinds of documents that you need to run a health system, even on the street, which is super cool. The second D is diagnosis, and we talked a little bit about that. Ignacio was saying, you can use this kind of for decision support, for a deeper understanding of what's the clinical problem. You can also use it in what I call telehealth 2.0, which is taking what we do today in telehealth and adding in the kind of vocal biomarkers, adding in all the kinds of face objective measures. We know people on antipsychotics, you need to check their blink rate. We don't do that, but it's really easy to do in a video conference. So there's a whole bunch of things where AI can help us get better information for diagnosis and for decision support. The third D is what we've been talking about, the delivery side. So actually being able to create the tools that can deliver care either as an extender or as a substitute for, or as part of crisis management, all of those things. And there, one thing we haven't talked about, but is tremendously exciting, it's happening a lot right now. There's several companies that are using these tools for training. And training everybody from licensed providers who need to get new skills or get upskilled to community health workers and peers and all of that. And there's a huge opportunity. Now, in all those, I get it, there's a risk, but to the point that you heard here, and I just can't say this enough, compared to what? Compared to what? You have to always ask, is it so great the way we do it today? Is the status quo risk-free? Is it actually working for people? It's, as Ignacio said, it's so broken. We cannot afford to be risk-free here. We've got to figure out some innovation to do better on all the problems you heard about. And yeah, we're going to make mistakes. There are going to be risks. But when you look at how we do it now, that's just not acceptable.
I want to add one thing that you mentioned. So I love that, Tom, you brought it out. Documentation, huge one, right? Why are clinicians spending their time at night documenting something that happened hours ago, trying to remember what happened, right? My fear as a clinical researcher, I had a teacher who always said, garbage in, garbage out. In God we trust, all others show documentation, right? And so that's our FDA mindset of measure, 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 get it right. And my fear, one of the risks I see is, if our AIs are listening into a visit and psychiatrists are getting it wrong 39% of the time and primary care are getting it wrong 70-something% to 90% of the time in mental health, are we documenting garbage? So the question is really, how do we get the quality up? And then also, how do we leverage these tools for one more, it's not a D, it's actually a P, for the fifth wheel of that, or for a pillar, I would think, Tom, is population health. Now one of the beauties of Clinicom is if you told me to screen all of New York City today, and I had everybody's email and phone number, within 72 hours, 96% of them would have completed a complete assessment for 80 mental health assessments. You can see who's violent, who's aggressive, who's suicidal, who's Asperger's, who's Tourette's, who's got enuresis, for 80 conditions, and do that all in one day. So imagine how many hundreds of psychiatrists you would have to hire to screen millions of people like that. So this technology will change the game and empower clinicians and not replace clinicians, but make clinicians more efficient, more effective, make sure primary care doctors are not prescribing the wrong meds, make sure that the counselors and people that are in the middle are routing and care navigating to the right level and cost of care, instead of these poor families that we all see riding the medication merry-go-round of, we tried that 3 times, we went to Dr. Bob, and then we went to Dr. Sal, and then we went here, and you hear these stories of these families, and I just know we can get it right on the first visit or two and not wait for the average, which is now, 11 years for SMI? 11 years?
I often get asked if AI is going to replace clinicians, and I always say, clinicians who use AI are going to replace clinicians who don't.
Yep. I think that is a wonderful, Allie, I'm sorry. Go ahead. And then we'll take one question from the audience because we have 1 minute left. But please, Allie.
No, I was just saying, great point.
Oh, yeah. It is. It's a great point, and I think it's a great point to end on. We have some work to do to build trust with clinicians, but we're going to do it. Can we take one question from the audience before we let you move on? Does anybody have any questions? Thanks, Omar.
All right, so first of all, Tom, very glad you crashed the party here. You've often talked in a bunch of different forums over the last few years about your almost unbridled optimism about the future of psychiatry and mental health. And so what are you most excited or optimistic about in the next 5 years?
You can't ask me to be optimistic today. I'm sorry.
Tom.
Yeah, that's fair, but we need you now more than ever.
Too
Very
soon.
true.
Yeah, it's a good point. And now you got to dig really deep for that. I am optimistic about this piece that we're talking about here. I think one thing that's held us back relative to other areas of medicine is that we don't have a measurement-based care system that really works for us. And that's one reason we haven't been able to improve outcomes, because we don't measure them, so we don't know often. These tools really allow us to do that in a very powerful, passive, objective, comprehensive way, so that every interaction with a patient, you have baked into it a bunch of outcome measures that get spat out, including therapeutic alliance, which is like a really powerful way to do this. And, you know, with respect to this topic about inequities, when you look at the data that we've got so far, there's not a lot of studies of this, and most of them are from the UK, which is interesting. But where you're putting this into care systems, you see that the people who get the most benefit from these additional tools are often the most marginalized. So the Limbics study that was in Nature Medicine last year, 130,000 people in the National Health Service got a kind of navigator to help them to get into care. That gave a 15% higher uptake into care than people who didn't have it. But amongst racial ethnic minorities, it was 30% higher. And amongst people who identified themselves as non-binary, it was 235% more effective. That's a really interesting observation, and not necessarily intuitive, but it tells you that on this particular topic around inequities, there's a real opportunity to make a difference.
Can I just add, we found the same thing in our data. We found that consistently the folks that do best with Wobot are young African-American males who don't have insurance, whom we try and over-represent in our data sets all the time. We're trying to, and other folks that, you know, are typically marginalized and underestimated. That's the thing. I think when you have, everybody deserves to have an interface, whether it's technical or it's human, wherein they're spoken to with, respect, equity, and human and dignity, right? And I think we have the opportunity to build that in to the technology tools that we use today. And wow, that is definitely worth getting out of bed in the morning for, even today.
Even today. And please join me in thanking this wonderful panel for their insights. Clap louder than that.